Hey guys, can you hear me?
Yes.
All right, thank you very much. Okay, so today I'm gonna touch up on the endocarditis prophylaxis. Uh, it came up today for one of our patients. So endocarditis prophylaxis came from the idea that it's really um, a high likelihood, not high likelihood, but it is there's a chance of having bacterial infection if you have prosthetic heart valve material or severe valvular disease that uh, can catch bacteria without the ability to protect itself from the small bacterial invasion that anyone can have from any kind of little procedure, dental procedure, or anything like that. So before 2007, it was very harsh. Anyone with murmur, anything like that, you have to be on endocarditis prophylaxis in the setting of dental procedure and any invasive procedure. But it turned out that it's really not easy for bacteria to invade the heart. Uh, so for that reason, it was actually the guidelines were adjusted now. Keep in your mind, no studies were done, no trials. Okay. Endocarditis happen very rarely, and there's really no way to make randomized clinical trials, nor you can do case control trials. So it's just really kind of consensus. So what I want you to keep it in your mind that we use mainly two medications for antibiotic for endocarditis prophylaxis. One is amoxicillin. We use 2 grams, 1 to 2 hours. I'm sorry, half an hour to 1 hour before procedure. Uh, uh, Amoxicillin, 2 grams, half an hour to 1 hour before procedure. And if you have a penicillin allergy, we use azithromycin 1 gram, half an hour to 1 hour before procedure. Now, if you want to get sophisticated, sometimes you can use clindamycin IV in the case of complicated GI tract in procedures and stuff like that. But in general, you can use one of these medications, which is amoxicillin or azithromycin. During my procedures, what I use sometimes is vancomycin or Ansef before the procedures when I do ablations in the setting of heart valvular disease. So that's number one. Number two is the heart conditions that you need to use antibiotic prophylaxis in. Number one, if you have any prosthetic heart material, okay, or prosthetic heart valve, such as tissue valve or mechanical valves, you have to use antibiotic endocarditis prophylaxis in these cases. If you have uncorrected congenital heart disease, if you have left atrial appendage occluder device, either amulet or Watchman, 6 months after implant or within 6 months after implant, or you have the ASD, VSD repair within 6 months after repair. Beyond 6 months, you don't have to do that. So basically, if you have prosthetic heart valve, if you have mechanical heart valve, if you have history of TAVR, if you have history of aortic valve replacement, if you have history of mitral valve ring, if you have history of mitral valve clip, these patients need to have antibiotic prophylaxis lifelong. If you have a history of Watchman or amulet, which are the left atrial appendage occlusion devices, or you have history of ASD, VSD repair, you have to use it within 6 months. Okay? Just remember that. And the procedures that we use these medications for are anything dental, even simple cleaning, because of most of these dental procedure will create a bleeding, and the bleeding may create some bacteria to invade. any kind of procedure involving skin, cutting the skin, any kind of procedure involving biopsies. However, if you're going to have TEE, if you're going to have endoscopy, EGD colonoscopy without biopsy, which is you can't predict, if you're going to have colonoscopy with possible bladder biopsy, in that case, you may need to give your patient antibiotic prophylaxis. But if you're gonna do endoscopy just to check or to inject medication or something like that, in that case, endocarditis prophylaxis is not needed. Okay. So that's basically what we do. So for the case from today was somebody needing TEE after Watchman. TE is not gonna involve biopsy or breaking the skin barrier or the mucosa barrier. That is really minimal risk of endocarditis or bacteria invading the blood, and endocarditis prophylaxis is not needed in this case. Have any questions about that, guys? All right. I'm gonna talk a little bit about aortic valve stenosis. So aortic valve stenosis, I'll talk about aortic valve stenosis, aortic valve regurgitation, okay? And we'll try to talk about valves in the future. We'll talk a little bit about a mitral valve. We'll talk about tricuspid valve and pulmonic valve. But let's start about aortic valves today. Aortic valve stenosis can be from different reasons. Two main reasons. One is degeneration of the valve itself, and we see it in elderly degenerative aortic valve disease. And the number two is bicuspid aortic valve. Bicuspid aortic valve prevalence is about 1 to 2% in the population. Usually happens in the 50s to 60s, and most of the time by 70s, patients will need aortic valve replacement. When it comes to aortic valve stenosis, you have to understand we have three grades: mild, moderate, and severe. Okay, and we go by the velocity of blood crossing the valve. The higher the velocity, the more severe the stenosis. And I just really want you to remember this: velocity about 4 meters per second, or aortic valve area below 1 centimeter squared. That's aortic valve stenosis, severe. In that case, you have to have a procedure done to take care of the valve. The procedures that we do, either balloon valvuloplasty, BAV, okay? Recurrence is extremely high risk of stroke, and you just insert balloon and inflate the valve and break the commissures between the stenotic leaflets. That usually recoil in about 3 to 6 months, and sometimes we usually do it if somebody that's not really candidate for TAVR or surgery, and it's just a quick fixation. But again, it's high risk of stroke, and yield is not very high. The TAVR, anyone above the age of 70 should be offered TAVR. And the TAVR, we do it from the groin. The TAVR procedure takes less than 1 hour to be done, and the risk is not really very high. There's some risk, about 5 to 10% of needing a pacemaker, because when you inflate the balloon and you inflate the valve, you may actually break the calcium, and the calcium may affect the His bundle system, and that needs sometimes pacemakers, about 5 to 10%. And success rate is about 97 to 98%. Okay. So if you have severe aortic valve stenosis, somebody above the age of 70, then TAVR is the way to go. And we have two kinds of valves. We have the Medtronic, and we have the Abbott valve. I'm sorry, the Edwards valve. The Medtronic valve, historically, because it's a little bit lower, it has higher chance of needing pacemaker. But they work the same, and they have almost the same survival rate and the same efficacy as tissue valve replacement. Okay, Patients need to be on aspirin Plavix for at least 3 months after valve replacement. They have to have endocarditis prophylaxis lifelong for any kind of dental procedure or any kind of invasive procedure. The SAVR, which is the surgical aortic valve replacement, it should be done for people about below the age of 65. Again, you have to go with STS score of, you know, what's the complication risk. If the complication risk from surgical intervention, then, you know, regardless of age, you have to send for TAVR. If the complication risk is acceptable below 5%, then surgical replacement is indicated. We have two valves. We have a tissue valve that you don't need to take anticoagulation. Some of the physicians they like 3 months of Coumadin after valve replacement, and some of them they don't care, just to take aspirin. Again, endocarditis prophylaxis is needed lifelong. Usually, survival of these valves is about 10 to 15 years. After that, they will get degeneration, and nowadays you can do TAVR for these patients. But sometimes if the aneurysm is very small, you can't implant another valve in it and you have to replace the whole thing. So just keep that in your mind. The other valves is mechanical, and now we have the Onyx valve. The Onyx valve is a reliable valve, is good, is mechanical, and INR can be kept between 1.5 to 2. Okay, INR should be or can be kept between 1.5 to 2. The other valves, the bileaflet valves, the one that we used to use, INR should be kept between 2 to 3, unless you have other reason for increasing the INR target, which is somebody with atrial fibrillation, somebody with history of ischemic stroke. In that case, you have to increase the INR target from 2.5 to 3.5. If you really look at the guidelines from 2021, we nowadays actually aim for a number of INR, not a range. For instance, if you have high risk mechanical aortic valve with atrial fibrillation, then your target INR is 3. If you have normal mechanical aortic valve bileaflet, then the target is 2.5. If you have Onyx valve, still they require 1.5 to 2. So I don't know why the change was made as such, but you know, we don't really talk about ranges. We try not to talk about ranges. We talk about target. You know, you keep your target at 2.5 or 3 or 3.5, whatever you need to do. Now, if your patient has a stroke on aspirin, I'm sorry, if your patient has a stroke while he's having mechanical aortic valve and the INR was at target 2.5, for instance, what is the next step? The next step is to look at aspirin. If there's aspirin, I'm sorry, if there's no aspirin, you add aspirin. If there's an aspirin, you have to increase the target of INR to 3. Okay, so let's say from 2.0 to 3.0, patient had stroke. Is there an aspirin? No, you add an aspirin. If there was an aspirin on his medication, then you have to increase the target from 2.5 to 3.5, which is 3. So you just need to go higher in terms of the target of INR. And remember that when it comes to mechanical valves, the target is like kind of G curve, right? So ischemic stroke risk becomes less, and then becomes here as the INR increase. As the INR increase, the risk of stroke will come down. As the INR increase, the risk of stroke will come down, but the risk of bleeding will increase. So you really need to have a happy medium where your patient has lower risk of bleeding, at the same time lower risk of ischemic stroke or ischemic complications. Okay. Moderate aortic valve stenosis, area between 1 to 1.5 centimeters square, velocity between 3 to 4. You just monitor these patients. Usually in the matter of 2 to 3 years, 4 years, it will become severe. And mild aortic valve stenosis, area above 1.5 centimeters square, and velocity between 2 to 3. In that case, you just monitor your patients. Aortic valve regurgitation, you don't do anything unless you have severe aortic valve regurgitation and you have either decreased ejection fraction below 50% or you have dilatation uh, uh, of the left ventricle more than 2.5 centimeter, more than 2.5 index in systole and more than 5 index in diastole. So you really need to look at the valve if it is at the heart if it is dilated in the setting of severe aortic valve stenosis, severe aortic valve regurgitation. If the heart is dilated, the heart starts failing. In that case, you have to replace the valve. If you have severe aortic valve regurgitation with symptoms, you have to replace the valve. If you have severe aortic valve regurgitation, the heart is squeezing nicely, is not dilated, and your patient doesn't have symptoms, you can wait. Seems like the heart can tolerate regurgitation and leakage much, much better than tolerating stenosis. And as we recommend for patients to proceed for intervention in the setting of aortic valve stenosis, we try to wait in the setting of aortic valve regurgitation because the heart can handle extra volume and it might take a long time. So aortic valve regurgitation is severe. You have to look at symptoms. You have to look at the ejection fraction of the left ventricle, and you have to look how dilated the left ventricle is before you send your patient for surgery. Certainly, if you have patient who's elderly and severe aortic valve regurgitation, these patients can't have TAVR as of now, is not FDA approved. And, for these patients, you should probably need to wait and diurese them as much as you can. In the setting of regurgitation, be careful, do not slow the heart too much. Do not slow the heart too much in the setting of aortic valve regurgitation because, in diastasis, when the heart is slow, you're going to have more and more volume coming back to the ventricle. So you really need to decrease the amount of, or the duration of diastasis by keeping the heart rate like 80 to 90 or something like that. In the setting of aortic valve stenosis, I keep, mentioning that you have to be careful not to diurese your patients too much because these patients are preload and afterload dependent. What does that mean? Preload dependent, they are dependent on volume. If you decrease volume too much, they will have issues with coronary artery perfusion. And if you dilate their blood vessels too much, the blood's going to pool outside the aorta, and the likelihood of having good perfusion to the coronary arteries will become affected. Do not dilate the blood vessels too much. Do not amlodipine, hydralazine your patients too much, and do not diurese your patients too much. Sometimes a little bit of volume, a little bit of hypertension is necessary, especially if patients are elderly.